Despite Dr. Gawande taking those really, really uncomfortable pauses, I'm surprised he's not a better speaker. We are on time. So we're going to take a 10-minute break, 9:25. We are going, there's a lot at the end that's really, really exciting, and we want to make sure we get everything in, and we're hoping to have some conversation. So we are going to stick to our time frame. So we've got a little break, stretch your legs, and we're going to start again promptly at 9:25. Thanks.
So now that this topic's a little more personal, I want to talk today about two medical professionals that greatly impacted our lives. On May 7th of 2010, my husband went in for a simple gallbladder surgery, which we became educated about that process. They suck it out your belly button now, and we thought that was kind of cool. It's an outpatient procedure, so we scheduled it on a Friday so my husband could go back to work on Monday. And it was just like the movies where I was sitting in the waiting room and out came Dr. Dan Patterson, who's an amazing surgeon here in Western New York, and he put me in a room and showed me pictures, you gotta love modern medicine, of my husband's gallbladder. Now, I'm a mental health counselor, so this really didn't mean a whole lot, but later on that night, he showed me pictures of what a healthy gallbladder looked like, and that gave me a very good picture comparing the two because they didn't even look like the same organ. And he explained to me that he couldn't remove Tim's gallbladder laparoscopically because it was hard. It was no longer a soft organ. So I had to make a medical decision. Do you want me to pull out and biopsy it, or open him up the old-fashioned way and take out his organ? Again, I literally have absolutely no education about this, and I didn't know I was starting a whole new phase of my life of having to make decisions like these where I was completely ill-equipped. But I did know one thing, and that was choosing my medical team in advance, knowing that my doctor's recommendations for a surgeon was going to be a great one. And I looked at him and I asked him the question that I've asked my vet several times throughout my life. What would you do if it's your cat or your dog? And I said to Dr. Patterson, what would you do if this was your life? And he said without hesitating, I would pull out. And I asked him that question because my intuition would be, open him up and take it out if it's full of cancer. And when I speak to doctors and nurses and counseling students, I ask them the question, what would you have done? And across the board, 90% of them say, take it out. And we were told later by the doctors at Roswell's that we were very lucky we had the surgeon we did, because surgeons like to cut. And he really made a great medical decision for Tim because it was the better option to just biopsy and not open him up. So I made it very personal for him, and when I did that, he was able to really guide me because I really, really was out of my league having to make that decision on my own. So then I'm going to fast forward to the last week of Tim's life. Of course, we didn't know it was the last week of his life, but his sleep cycle had gotten screwed up, and we went into hospice, the inpatient facility, and he was going to get back on his sleep cycle and come home like he wanted to, but that's kind of not the way it worked. And they called him a surprise guy at hospice. I love hospice people because they do one thing and they're experts at it. And I knew from watching my mother pass away 3 years earlier, that they were going to let us know when the time came, and we were all going to sit around his bed and say goodbye, just like we did with my mom. It was a very peaceful, sacred event. But that shows you what I know, because Tim had other plans. And he would go into these very deep sleeps. He would tell us before these deep sleeps that he was ready to go, and he was ready to die. And he would be gone for 12 hours, and we would wait patiently, and then he would wake up and ask for pudding and soup, and get up and eat pudding and soup, and we'd be like, okay, not today. But he became eventually, over that week, less and less responsive. And a few days before he died, they had discovered through tests that his oxygen level was very low in his blood, and I had another medical decision to make. We could give him some transfusions, but that would require moving him to a different facility. It would be pretty much an all-day process, and did I want to do that? It was a very hard decision for me to make, and again, I looked at his doctor and I said, what would you do if this was your husband? And she quietly took my arm and pulled me aside and took me into a room, closed the door, and she said, that was my husband 3 months ago. Dr. Megan Farrell is an amazing, amazing physician and an amazing woman and an amazing person. And I was flabbergasted to find out that it was very personal for her as well. And she told me a little bit about her husband and the situation she was in and the decisions that she had to make. And she helped me work through what I was having to face, and we made the decision to not transport him and put him through that ordeal. But I never forgot her, and several months later I was thinking about what happened on the day that Tim died, because he had been unresponsive for about 48 hours and had his eyes closed. And we had had someone come in to check him because he was making some different sounds, and I wanted his breathing checked, and they assured me that he was actually doing really well, and in spite of some of the sounds, his lungs were clear, and it wasn't time. And everyone dispersed for lunch, and about 5 minutes after that, we were standing around talking, and I looked over and Tim's eyes were open, and they hadn't been open for several days, and so that caught my attention. And I went and looked at him, and I said, I don't think he's breathing anymore. And everyone said, of course he's breathing, they were just here, they just looked at him. And so we went and got the nurse, and she checked him and looked up at us and said, yes, he's gone. Now, I was pretty, you prepare for this. We only had 5 months, but we'd been talking and talking and talking, and yet when it happened, I was still, for some reason, quite shocked. And the doctor came back in, and if you know my husband and I, we have a pretty odd sense of humor. We're both pretty funny, but I said to the doctor, well, you know what I get to live with is my last words to my husband, because I was going to do all that. Go to the light, it's okay, we're okay stuff. But I didn't think it was time, so I had whispered in Tim's ear, you should have seen that doctor who just checked you, she's really hot. So, about 6 months later, I started thinking about Tim opening his eyes, and it really bothered me and haunted me. Because I really felt like I tried so hard to be there for him, and I thought that maybe at that last moment, I let him down because I wasn't there and that he was scared. And then I got really mad because then I thought, he opened his eyes to see that doctor. So I called Dr. Farrell 6 months later, and I said, I know you probably don't even remember me, but I just wanted to ask you some medical questions. And she said, of course I remember you. And she talked about the whole last week of Tim's life and explained all kinds of things to me. And then 2 years later, when I wrote my second book, she wrote the foreword for it because she was perfect. She was the doctor and the hospice person, but she was also a widow and a mother, just like I was, and she wrote an amazing foreword. So you make a tremendous impact with the people that you work with. So I think my opinion is what I want to leave you with, that the best thing that you can do for your patients and the people that you care for is to never stop being human. Keep being human, keep being real, grapple with the concept of death yourself so that you won't be afraid to talk about it with the people that you're caring for, because we need answers and we need to talk about it. So stay human and keep listening.
That's a real hard act. I'm Deborah Luczkiewicz. I'm one of the other doctors over at the Hospice Inpatient Unit. Megan Farrell's actually my boss, so I have had the pleasure of working with her for quite a while. I'm just going to take a few minutes to talk a little bit about hospice. I say it's the who, what, where, when, and how. And let me set the mouse. So people are eligible for hospice if they have an expected prognosis of 6 months or less, and they're not pursuing curative or aggressive treatment. This is a fully funded Medicare benefit, so no cost to patients. Most other insurances, not all, but most other insurances have a similar rider or benefit in their plans. It's pretty touchy. So hospice is an interdisciplinary approach. We provide pain management, symptom management support for patients and their families facing terminal illness. And there's a long list of services that can be provided. Hospice physicians, nurses, social workers, chaplains, on and on, medications, equipment. So a lot of benefits that can be provided. I think sometimes people think hospice is a place. I hear physicians say, I'm going to send you to hospice. It's not a place. Hospice comes to someone wherever they live. So that may be their home, a family member's home, nursing home, assisted living. We do have our inpatient unit. I don't know, I'm not good with directions. Somewhere around the corner over on Como Park. That's really an acute care unit. You think of it like a hospital. If somebody's having a medical issue, they come in there for symptom management, but then they have to have a discharge plan, much like in a hospital. That facility is also used for respite care to provide caregivers a break. And there are beds in many of the local hospitals that are managed by hospice, and those are under the same regulations as that inpatient unit, so for symptom management. There are a lot of situations where hospice can be part of the conversation. So certainly if you have someone who seems to have a prognosis of 6 months or less, hospice is probably one of the options you should be discussing. You can also bring up hospice in situations, for instance, if you have a patient with cancer who's decided not to pursue treatment or for whom there is no more treatment being offered. So you kind of plant the seed. You say, hospice is something that may be a benefit to you, if not now, sometime in the future. And your patients who have progressive chronic illness, so think about CHF, COPD, neurological disorders, dementia. Again, planting that seed for the future kind of helps pave the way to those conversations later. It doesn't have to be a one-time sort of topic, and you don't want it to be as much of a shock. So the ways you might say this, and these are of course very condensed versions of conversations, it would be a much longer discussion. But for that patient who may have that chronic progressive illness, you might say something like this. As your heart gets weaker, we may get to a point where more hospital visits, more medications aren't making you stronger or better. At that time, hospice will be able to help you and your family keep you comfortable at home. So just a way of saying, this isn't all we have to offer, hospital after hospital after hospital, that there are other things that can be offered even when the kind of standard medical treatment is no longer providing enough benefit. For that person who might not be getting more treatment for their cancer, you might say, since you've decided not to have chemotherapy or there's no more chemotherapy available, I recommend contacting hospice. They can talk to you and your family about what's available, whether it's now or in the future when you're ready. So a referral to hospice or a call to hospice doesn't commit someone to enrolling that day. It can be just for information. And then if you're seeing someone and it's clear that they're declining, the prognosis looks like it's in that less than 6 months window, you might say something like this. Unfortunately, your mother's dementia is continuing to advance. She's declining. I think prognosis is more in the range of some number of months rather than years. I'm going to call hospice. I'm going to make a referral, and they can come talk to you about how they can help you and your mom. So those are just some ways that you might introduce it. A few of the myths and misconceptions, I think, that are sometimes barriers to understanding what hospice does and doesn't do. So number one, there's the perception that symptom management, palliative care, hospice care can hasten death. And there's a whole lot of studies that have looked at this. These aren't the only ones. There was an interesting study in the New England Journal in 2010 of patients newly diagnosed with lung cancer. Half received standard treatment, whatever their oncologist recommended. Half received standard treatment plus palliative care. And very interestingly, those who received palliative care lived longer. Median survival was 30% longer. And if a drug company could come up with something that gave lung cancer patients a 30% increase in survival, that would be a blockbuster. So symptom management actually can help extend life. Other studies, a study looking at Medicare beneficiaries enrolled in hospice, those who received hospice care lived almost a month longer on average. A look at whether opioids hasten death, which is another misconception. Multiple studies have shown that appropriately dosed medications do not hasten death. And the last study I listed here was interesting. This was in the journal Chest in 2004. It looked at patients in ICUs who are on ventilators and who are undergoing what we would call a terminal wean. And they said, all right, does the use of opioids, which help with the sensation of shortness of breath, or benzodiazepines, which are typical anxiety medications, both or neither have any effect on how long someone survives after being taken off the ventilator? And there was no correlation between use of opioids, but very interestingly, those who received the benzodiazepines actually lived longer. So in many cases, symptom management actually not only improves quality of life, but may have an effect on longevity. A few other misconceptions. Some people have the impression that hospice is just for people with cancer. In 2014, it was about 37% of the patients nationally. The next 37% were heart, lung disease, or dementia, and the remainder were other diagnoses. So any terminal illness, any terminal decline would qualify for hospice. There's the thought that if I enroll in hospice, I have to give up my doctors. Not true. We actually encourage primary doctors to continue to be involved with their patients. Our physicians then can serve as consultants, can make home visits, can make recommendations. There's the impression that hospice is just for the last few days of life. I think that impression comes a lot of the times because people are referred very late to hospice. The median length of stay nationally in 2014 was only 17 days. So if somebody is enrolled in hospice for their last few days, last week, or last 2 weeks, when you think about that long list of benefits, there isn't time to put a lot of it in place. There isn't even often time to get symptoms under really good control for that quality of life. So sooner is better. And if you're unsure of prognosis, we ask you to think about what we call the surprise question. So if you look at someone who's had an overall decline, multiple hospitalizations, if you say to yourself, would I be surprised if I heard that this person passed in the next 6 months? If you say, no, I wouldn't be surprised, then a hospice referral may be appropriate. And lastly, there's the thought that hospice means giving up treatment. And I work full-time for the Center for Hospice and Palliative Care, but I used to also be a primary care doctor. And the way I explain it sometimes is, as a primary care doctor, I would be inclined to look at what diseases my patients had and what their lab numbers were to help decide what they needed. But as a hospice doctor, I look at the person, I look at their symptoms, I look at what's important to them, what their goals are, and that helps guide me on what to offer. So if there are treatments that are going to help with symptom management, quality of life, reaching a goal, they are available under hospice. It's just sort of the focus isn't the lab numbers or the guidelines. It's what's important and what will be of benefit. So we'll have some opportunity to ask questions during the panel if you have anything. Thank you.
I hope my slides are on here because I think I was supposed to go last, so let's hope. So, anyways, I'm Jackie Schneider, better known as Katie Grimm's healthcare proxy. But I have a long list of things that I do. I actually, I'm the chief of palliative medicine over at the VA, where really a lot of the education and focus of where we teach our residents and fellows along with Erie County Medical Center, Boswell Park Hospice occurs. I'm also an assistant professor of medicine in the Division of Geriatrics and Palliative Care. And I guess most importantly for me is I'm the associate fellowship director. So I'll explain a lot of those things. I see one of my fellows in the audience, which makes me really happy because she got up really early on a Saturday, even though I grumbled about it. So my talk is not, I don't have a ton of stuff that I'm going to put up there. I really want to just let you guys know what we do in the community. So I found this baby on Google, and I decided that Katie and I talk a lot about this, and I know Deb and I do as well, is that when should we really be starting this education? And when you get to me, or one of us, it's way too late. So, death and dying really should be started, the education should be started in the home. It should be started when we're younger. It shouldn't be like, oh my gosh, this is something that's, avoidable. A lot of my patients say, well, I'm not gonna die. Because last time I checked, yeah, we do. So I don't know how that's gonna happen. It's an interesting situation. And I think what troubles me is that I have residents that come to me and say, this is the first time I've ever talked about this, or I've done this. And I think to myself, really, has anyone not died in your life? How am I the one that's getting you at this point? So I think we don't talk about it enough. It's feared. Do I ask my mother? Of course I do. And she's like, ew, I don't want to talk about that. But I lost my dad at 58, so it's got to be said. My next little picture is this little girl. And, again, with our patients and everyone we meet, it's oh my gosh, death happened, and then you make that face. Like, how did this occur? I say that to my residents all the time. What, were you surprised that this guy was gonna die? And they say, well, no. Well, damn it, why didn't you say something to them about it before, some crisis hits? But the problem is that, and what we talk about all the time is, we don't talk about this. We don't teach it even. And that's why so here we are, we have some adolescents, and this is really the time that I think that we should be talking about this kind of things. It should be in the schools. It should be like health class. It shouldn't be, when you have your sex ed and all that stuff. But what about what's really going to happen to grandma or those types of things? That's my little spiel. I know it'll never happen. But, a lot of my patients say, like, we're going to fight cancer and we're going to fight ALS, and I'm totally all for that. But at the end of the day, what is going to happen is that we will die, and we have to talk about that and how it's really going to happen. So as you can see, I'm going through the continuum of education. When I was in college, I can't say that I learned anything about death and dying. I can't say that it's talked about. I was a neuroscience major, so I did some really disgusting things on rats and, gave the rat Parkinson's disorder or something. It was really awful. But, those types of things we really didn't talk about. And then we get to medical school, which is, I think, a really prime opportunity to be discussing these things with our medical students. I'm going to stand up here and hopefully the lightning doesn't come out, but I think we could do a heck of a lot better here in Buffalo. I know that there was a case about a lung cancer patient in one of their discussions, and then the lung cancer patient died, and then some of the descriptions from the medical student was, oh my gosh, why are we talking about this? We're taught to cure cancer. We are taught to fix this thing. And my mind is like, where? If you're a medical student going to be doing these things in the hospital and you're writing that as a comment. And I thought, oh, my heart ached. So what really happens in our university, we have an intersession where most of my colleagues, talk to third-year medical students who are in the midst of their clinical rotations. We talk to them really about having the conversation and goals of care and things of that nature. But it's about a 2-hour time period. And I know that I'm vying for a very, very, very precious period of time in the curriculum. And I'm hoping, I see some people in this audience that have some pull on that. I'm not going to call them out. But anyways, I'm hoping that, eventually we'll get on a little bit more out there, because this is kind of something that is happening, and it's happening to all of us. And when the residents come to me, and they look like this. So when the residents come to me and they say, I've never done this. Well, what is actually happening in our residency is that internal medicine mandates second-year residents to rotate with myself and with Dr. Case. Amy Case works over at Roswell Park. She runs their palliative care program there. But that's it. What happens to the emergency medicine residents? So family medicines, I know, do rotate with Dr. Grimm, but I don't know if it's all of them, and I don't believe it is. What happens to the surgeons who are meeting you, Darcy? What happens to all of those other residents? And unfortunately, they do not get any education on this stuff in their residency. Urologists, the urology residents, they're taking out prostate cancer, and they're dealing with urothelial cancer. But unfortunately, they look like this because they're tired and they're beat down. But unfortunately, they're not getting set up with the education to talk about these things. What also happens is that we take on medical students, which is great, but it's an elective. So Katie, I know Grimm and I take on medical students. Most of them are fourth year medical students at the University of Buffalo here, but they're the ones that want to do it. And so what about the ones that don't? And it may not be that they don't. It may just be that they don't have the time, or who knows what's going on with their other electives because they want to get a letter of recommendation. But that's really where we are in Buffalo in terms of palliative medicine education. As you go through and you get through residency and you get through to a fellowship, we do have a fellowship here. Dr. Amy Case and I run that fellowship with the help of these wonderful physicians in the room. We have 4 fellows, and it's an ACGME accredited fellowship. We used to have 2, but because based on the need, just like Katie said, oh my God, you have to have an advanced directive talk, or you have to have goals of care. So palliative care consult, and away it goes. So that's kind of what's been happening. And so we have a ton of need. So now we have 4 fellows, which I think is great, and they're going on and doing their thing. But I think what I'm trying to say is that you can see there's a whole lot of gaps. There's a whole lot of gaps in education, and it starts in the home. It starts where Katie was saying with the Conversation Project and everyone having those discussions around their dinner table. Because when I get those patients, like my ALS patients, which last time I checked, that's a pretty clear trajectory, who say to me, what do you mean I'm gonna stop breathing and I'm gonna have to have a tracheostomy and a percutaneous, PEG tube, feeding tube? And I'm thinking, oh my goodness gracious, how are you coming to me saying that? You can Google this disease. So I think a lot of this stuff needs to happen in the home, and I'm hoping very, very much that, we give lectures and we go out there and try very hard to educate everybody and do as much as we can, but there's only so much of us. So I'm hoping that as a whole, we'll come together and really do a better job at educating everyone. But mind you, I only talked about physicians. There are nurses in this room, social workers, case managers. So I guess you can see what I'm trying to say is there's a big gap. And I'm looking for all of you guys to try to help with that. So that's my spiel. So hopefully you're not like this at the end of this.
This was my paycheck, so I hope I didn't. One of the things to be the middle speaker is that 50% of what you want to say is already spoken. And so I try to be smart. I told Dave, I'm going ahead, and what I miss, he can catch on that. Darcy said one thing very good, that, be human. We are human beings delivering human care. We are not industrialists, we are not technical. We are just talking about human things. And human things, there's a beginning of life and there's an end of life. And we have to be cognizant of the fact. My first exposure to palliative care was when I was a third-year medical student. I thought I was the smartest doctor on earth at that time, like any third-year medical student. And I was visiting home, and I visited my grandma. I was studying in Pakistan, went to Tanzania, where I come from, northern Tanzania. And I visited my grandmother, and she was 84 years of age. She had congestive heart failure, she had pedal edema, she had PND and the whole things about congestive heart failure. And I knew that she was pretty sick. Now, there are 2 things which my grandma really loved, and one was to smoke. She used to smoke 3 cigarettes a day, only 3. Those of us of my age would know that there was cigarette paper, you put a little tobacco in, roll it up, and she used to sit cross-legged after every meal, look at the mountain from her window, and enjoy it thoroughly. I still have a picture of that, my grandma enjoying her cigarette. Only 3 cigarettes a day, the small ones, not a big one. Secondly, she loved to have pickles with every food. Pickles contain salt. So I go, third-year medical student, know everything about heart and all those things. And her GP came home to visit her. At that time, the general practitioners used to come home and take care of the patients. So I told, Doc, do you know my grandmother smokes? And she has pickles. And that is bad for heart. The GP looked at me, you shut up. We still have a long way to go. Obviously, I was starved. I was sick. I went to my dad, said, fire this guy, he's a quack, he doesn't know anything. So down the road, after a few years, I started thinking about it. It's long down the road, okay? Now I'm thinking about it. So there are 3 things which happened in that conversation, brief conversation with the general practitioner. I had half-baked knowledge about medicine, not everything. Secondly, I was emotionally involved with my grandmother. I loved her. And number three, I was turfed. The general practitioners did not attend to my concern also as a family member. So now in our daily practice, I think there are three things happening even now. When the patients come to you, they have had three super specialists talking to them and discussing with them. Who are they? Dr. Google, Web MD, and Dr. Oz. Okay? So they get the, and plus they are emotionally involved. They're talking about the care of their loved one. So what do they want? They want time from us. And that is the thing we need to give them. So in my daily practice, there are certain triggers which initiate this discussion. And I agree with you, Dr. Schneider, we should start educating right from medical school down the line. Even now, I need a little bit of more education about that. But the trigger is that we see a lot of elderly patients with multiple disease. And the trigger is multiple hospitalization, multiple ER visits, and multiple visits to various specialists. An average Medicare patient sees about seven specialists a year. 7 specialists, primary care physician, nurse practitioner. They're just going from one doctor to another doctor. And nobody is asking them, what do you want? You are at that stage of life when you need extra care. But we are always talking about disease because our training, I agree with Dr. Schneider, is disease-oriented. We are not person-oriented. We are not patient-oriented. We are just disease-oriented. We think about disease in a person rather than a patient having a disease. We don't talk that language. So in our practice, we started talking more about healthcare proxies and end-of-life care and palliative care. But this is, everybody has got different style. I have my own style. Dr. Hartman has got his own style. Kathy, you have got your own style. So the hospital is different. Outpatient conversation is different. Hospitals, I don't think the discussion should be in the hospital. It should be discussed right in the primary care office. That discussion should start with us, not with you when they come in a trauma center. That is not right. So we start talking, and there are a lot of cases I can share examples of. Actually, there was one patient who was admitted 3 times in 3 weeks. Not admitted, went to the ER 3 times, 89-year-old gentleman from assisted living with dehydration. I met his daughter at Apple Store right here. And I asked her, how's your dad doing? She said, I think we need to do something about it. He's been going to the ER multiple times. He said, can we meet tomorrow? Now the thing is, when I want to discuss palliative care, I like it to be end of the day, not beginning of the day, so that, if it goes beyond half an hour, 45 minutes, I have time. I'm not rushed up the usual way. And Mr. Smith came to my office, and he said, Mr. Smith, how are you doing? I'm tired. That should be a pointer that now we need to initiate the discussion further, go further and probe. And there are 3 steps I take. I ask them, tell them, and then ask them again. Ask is more, tell is very little. I tell them very little. I just find out what do they want. And actually, they help you make a decision for them. And I ask them, what do you know about your disease? And guess what? They go to 50 specialists. I have a patient who goes to 3 cardiologists. One is an invasive cardiologist, the other is a non-invasive cardiologist, and one is a cardiac surgeon. And also this patient goes to 2 ENT. I'm not joking. One is for right nostril, one is for the left nostril. I go to multiple specialists. So they ask them, what do you know about the disease? And they'll be so confused. They don't know what is happening. Oh, I have 5 stents. I'm going to survive forever. I've got atrial fibrillation. I'll be fine. I don't even need to do anything more than that. So then they end up in the hospital again and again, and that is the time we need to initiate more discussion. I had a patient who was diagnosed with cancer of the pancreas. And smart lady, 66-year-old, went to the hospital for abdominal pain, and we diagnosed her to have CA. I went to her and asked her, what do you know about yourself? And she said, I think I've got a malignancy. I said, you're right. She knew, patients know about it. Then I asked her, what do you want us to do? So you discharge me right now. I have a wish list. I've got a bucket list. I want to go to Paris. I've never visited that place, and I want to go right now. I'm already talking to my sister. By evening, she was on the plane going to Paris. So we need to ask patients. We never ask these questions. We should be finding out, what do you want from us? Is this treatment really valid? There's another thing. Sometimes there's a tremendous lack of communication between us. I remember a patient, 87-year-old lady with ischemic cardiomyopathy with ejection fraction of about 15%. And I took care of her for about 7-8 years, and one day she had a GI bleed. She was uncomatous, so she ended up in the hospital. They transfused her, put her into heart failure. This is what volume overload does. And she came out, and now her ejection fraction dropped to 10%. We started this discussion, and my regret is that I did not push this discussion further. I said, okay, we'll meet again next week. Unfortunately, the same weekend she got admitted to a hospital with flash pulmonary edema. It was in a remote hospital. ER didn't call me. The hospitals didn't call me, cardiologists got involved. They said, we've got this synchronous biventricular pacemaker which is going to help you. Guess what happened? After 2 weeks, she developed fever, chills, she developed an infection of the skin overlying the pacemaker. It became necrotic. She went into septic shock. She was sent to ICU again. She got intubated, and she had a miserable death. My regret, and that is a regret I need to share, and all of us, I think, have the same regrets. Probably we did not push further with that particular patient. We've got good stories, those stories are good. We would like a patient to have a good death, quote unquote. I'm sorry to mention those things, but we don't want them to have a bad death. It is affecting the care of the patient, it destroys the families, it bankrupts them. Our country is already suffering with the economic downside just now. We need to take more care of our patients. And that care should start in the primary care office. I don't think the hospital is the right place. And plus, we are reaching out to specialists to interact with us. We do interact with them. Certain cardiologists, certain oncologists are up front and discuss openly, but there are certain times they don't want to talk about it. That's another thing I want to talk about. Goal setting. Somebody did mention about you set the goals. What do the patients want? I had a patient with metastatic breast cancer a few years ago. I said, you have metastatic breast cancer and these are the options available. He says, Doc, my daughter is getting married in 1 week. 1 week. If I get that 1 week, I'll be happy. So that is the goal setting. There are certain patients who just want to be reconditioned. They just want to start walking. There are certain patients who want to help in gardening. So these are the goal settings, and we need to ask them. It is all asking business. Ask, little tell, and more asking. And unfortunately, in our practice, and when you teach communication skills to the residents, it takes only 17 seconds for us to interject. I think we should hold back, especially when we talk about palliative care, give more time. I'm sure Dr. Hartman has more to share, but there's one more thing. We need to empathize with the patient. We cannot be like a professional. I'm a doctor, you're a patient, you're dying, and we're going to talk about that. No, we are human beings taking care of human people. Thank you very much. This book is great, A Death Prolonged. And it's written by Jeff Gordon. He's a hospitalist, and he's written multiple conversations he's had over a period of years with medical students, with the residents, and with the other doctors. And this is a great book to read. It's an easy book to read too. Thank you.
I'm David Hartman. I'm a physician, been practicing internal medicine for 31 years. 28 of them have been in Buffalo, New York. I've too also experienced the death of a spouse 17 years ago, 2 days after our daughter's birthday, 7th birthday. So having gone through having to deal with specialists and dealing with conversations that needed to occur between family members, I also now can see the other side of the coin. I think two things are very, very important. Communication between the physician and the patient and the patient's family and everybody involved as to what their understanding of the disease is, especially any chronic disease, very important. And everybody, and I paraphrase, what does that mean to you a lot? I think it's also then important, what is it that agree? What do you want out of life? And once they understand it, the third thing is there has to be ultimate communication with the specialist. Everybody, I can't think of a single case of somebody with a chronic disease has not been to at least 2 specialists. So there has to be very pragmatic discussions, because how they present a disease and how you present a disease is sometimes it confuses the patient, and therefore when you ask them what they want, it makes it very difficult. One of the sayings that I really hate are the ones that a lot of the oncologists say, well, we can treat this. Every patient I've ever asked, when I ask them, what do you mean you can treat this? They say, well, they can cure this. And so their outlook on something is much different. And we need to try to educate them. We as primary care physicians we can treat anything. I mean, you can push chemo on somebody 30 seconds before they die. You're treating them. So I think I'm going to give 2 practical approaches to 2 patients that I had. One was a gentleman who didn't take any medications. He was 60 years old. All he did was smoke. And every year he'd come in, his numbers on the blood tests, everything looked great. Yeah, I know, doc. You don't have to tell me about smoking, I know. So he always liked to have his physical in December so that he had a clean bill of health for the year. So he would come in, and later on that year, so he came in, nothing on complaint. A couple months later, went to New York City, walked all around New York City with his son, had no problems. Came in to see me in May and says, oh, doc, I'm having a little DOE, no chest pain, nothing else. I examined him and he had a sentinel lymph node. I said, oh God. So I ordered a chest x-ray on him. This was late in the day, the x-ray facility was closed, but I did blood work on him. The next day the blood work comes back, his liver tests are elevated. So very quickly I did, and I called where he was going to have his chest x-ray, ordered an ultrasound. He's got lung cancer, he's got a paralyzed diaphragm from that, and he's got mets in his liver. 2 of them look very amenable to biopsy. So I asked him what he wanted to do. I told him what I thought was it. He said, so we got a biopsy. 48 hours later, he had small cell carcinoma. I made 2 phone calls. Before I even talked to him, I made 2 phone calls to 2 different oncologists that I know that I can trust. I said, this is what I've got. This is how I'm going to present it to the patient. I'm going to have him see you, and then I'm going to have him go see somebody else for a second opinion. I set him up for 2 opinions. I said, I want you to be honest with him. So he went, and he came in to see me. We gave him the diagnosis. The next day, he was seeing oncologist 1. The day after that, oncologist 2. He came back to see me day 3. He said, doc, they told me exactly what you told me they were going to tell me. All I want to do is play golf the rest of my life, for what I have left. He said, they said maybe they could prolong my life 9 more months. But of those 9 months, 8 months, I'm going to probably be sick. He said, I may not play golf the rest of this year. He said, doc, I want you to be the first to know. I've elected no treatment. We're going to play golf. He was on the golf course every day of the year. Died in November. He did what he wanted. Number 2, gentleman I had known for probably since I started here in Buffalo. Coronary artery disease, slowly progressive. He had a couple myocardial infarctions, ended up with an ejection fraction of about 15%. In the meantime, he had developed lymphoma. He had had stage 4 kidney disease. He had had a GI bleed. He was in atrial fibrillation, so we couldn't anticoagulate him. And he one day ended up in the hospital, and they said, oh my God, we got to put an AICD device in you and deal with this. And they presented it as if he was going to live forever and he was going to have his stamina back. And I said, well, what is your understanding of this? And we've been talking about that this was a progressive disease, and this cardiologist was putting it on. And after several conversations with the cardiologist and him, his understanding was getting this AICD device, he was going to be able to get up and walk around. He wasn't going to be short of breath at night anymore, and he could have fun with his grandkids and get out and run around with them. And I said, no, that's not what that's going to do to you. You're still going to have these symptoms. He elected no AICD device, and probably about 9 months later, he just didn't wake up. And the family was actually very happy with that. And we had multiple family conversations. But part of this, and each one of these, was me making phone calls to the specialist, them calling me back, and that we were given the same message to the patient. If you cannot give the same message to the patient, they get confused and they cannot make rational decisions that are the best for them. So what I want to emphasize, it has to start with us reaching out to make communication with these people and to get a core group of specialists that you feel are going to be realistic. And tell them, if you're not willing to have that conversation with them, I will. But we need to be on the same page of what you're going to present, what they can expect 4 or 5 years down the road, 4 or 5 months down the road, how this is going to go. We need to be on the same page. If we don't do that, we don't do service to the patient. So from a practical point of view, I want to emphasize that communication is paramount in order for a patient to make a decision that's right for them based on what they want. Thank you.